Our next speaker is a medical doctor who dealt with an addiction, who dealt with people with addictions in Halifax, working for the Canadian Navy. Now he runs an innovative addiction service that works only with the most severe cases. Despite this, not one of his patients has died of an overdose. And he and his team have helped them achieve a remarkably high quality of life. People come from around the world to see what he does. Please welcome Dr. Scott Macdonald.
Thank you, Sam, for that kind introduction, and I'm very grateful to the opportunity to be here. I'd like to make a couple of acknowledgements. I want to thank the staff at Crosstown Clinic, the nurses and clinic workers who were there tonight, just down Hastings Street, providing supervision and support and prescription heroin, diacetylmorphine, to the participants in our study, the patients who are there today, to the research team, and particularly Eugenia Uberiokas, professor in the School of Population and Public Health at UBC. I'd like to start by talking about another think tank, the Cato Institute in Washington, D.C., which invited me to speak to them several years ago. They're a Republican think tank, and they support prescription heroin. And they've come to a position that policymakers are currently stuck in a state of denial about the true cause of the overdose crisis, because it's not opioids, it's prohibition. Here's an example of some of the evidence here in North America. You know, the problem of a toxic drug supply is not yet addressed. And the prescription of opioids is reduced, yet the number of deaths continue to surge. So it isn't opioids and it's not prescribing. It's something else. How did we get to prescription heroin and the clinic that I have and the small number of pilot programs that are here in BC? Well, opioid use disorder is a chronic medical condition. We've got good treatments in methadone and Suboxone, the standard treatments, but they don't work for everybody and they don't work all the time. And there's emerging evidence from our studies here in Canada, but mostly in Europe, Switzerland, the Netherlands, that have been providing prescription heroin for many, many years, particularly starting in the UK. The UK, United Kingdom, is providing prescription heroin to a few hundred people for nearly a century. And people go to a pharmacy, pick up powdered diacetylmorphine, they take it home and self-administer in the comfort of their homes, go back to the pharmacy in a week. The Swiss looked at that in the early 90s, late 80s, knowing that they had a problem with open drug use and people dying, and they said, well, we don't quite like that UK model. Let's do something supervised. Methadone is good, but it doesn't work for everybody. We're pragmatic. Let's deal with this, and we'll provide syringes in a supervised fashion. Very quickly, the problem got better, and people in North America, researchers said, this is something we need to explore in North America. And that led to the Naomi study. It asked the question, is prescription heroin, diacetylmorphine, superior to methadone in that population that continues to inject despite attempts at methadone? And yes, it is. Published in the New England Journal of Medicine in 2009. The study ran from 2004 until 2008. New England Journal, respected journal. Unfortunately, we weren't able to transition to a program at that time, but Denmark looked at those results and said, we don't need nobody studies. We're going to expand prescription heroin. And that initial rollout in 2010 was so successful, it's now integrated into the healthcare system in Denmark. We didn't get a program then, but it led to our follow-up study, Salon, which asked the question, is hydromorphone a licensed analgesic if it's as good as diacetylmorphine? We were worried that we'd never get access to diacetylmorphine because it's too controversial. But it's not. It's just an evidence-based tool in the toolkit, another option for care. And we now have a licensed producer here in Canada. Diacetylmorphine is available to any jurisdiction or province that might want to access it. Diacetylmorphine is more effective than methadone in that population that continues to inject. It also reduces societal costs over a lifetime, about $140,000 in saving rather than continuing the standard treatments. And for policymakers, it also reduces crime. So in Denmark and Switzerland, the prescription heroin was not expanded because it was better care. It wasn't expanded because it reduces mortality and assists people's lives. It's been expanded because it improves public safety, reduces public disorder. And my most recidivist patient at Crosstown had been in and out of jail over 200 times. And since he's been in our program, he's not been back to jail. That's just one example. So how do we close that care gap? We've got good options on the recovery abstinence side of the continuum, but there's thousands of people that aren't ready for that option yet. And we need to normalize options like prescription heroin. We need to offer it in a patient-centered way. If somebody was looking for a safe opioid high, I need to have a tool in my toolkit that can meet them where they are at. And as a prescriber, I might see that as improving their function. And we need to have outcomes that are geared towards patients and what they are seeking, patients and families, not just abstinence as an outcome measure. The models are out there. There are countries like Netherlands, Switzerland, who've integrated this kind of approach into their healthcare system. There's probably 100,000 people in BC who would meet the criteria for opioid use disorder, and there's probably a few thousand, 10,000, 12,000 who might need this kind of a treatment. We need more approaches. We need more tools in the toolkit. The options and the approaches we need to take, the models already exist. Let's make it happen. Thank you.